See, by discussing hyperthermia, we understand that heat can kill a person even without touching its skin directly. But when the heat directly burns over the localized portion of skin, we enter into the territory of burns. What happens in burns is that there is a part of skin. Now we are entering into the part where we are seeing the localized effects of heat. So, and this heat will first discuss dry heat. So I'll make a flame. I'm making this flame with blue color. But let's think that this is a flame of fire. This is affecting one body part. Let's say I'm drawing a hand. Okay. So what happens if particular dry heat is affected to one body part? That we'll start discussing now. First of all, what are the determinants of burn severity? The determinants of burn severity are, as it's given in the slide, it's that the temperature of heat source matters, the duration of exposure matters, and the ability of body to dissipate heat. Now, most important thing, it's not just how hot the surface is, or how hot the flame is. Time is also important. So what's important is the temperature into time, into contact surface. This will decide, this whole thing is going to decide the direction and prognosis of burn injury. Okay. For example, let's say that 44 degrees Celsius, this is a very low temperature. Our body temperature slightly higher than our body temperature. Our body temperature again 37 degree. So 44 degrees Celsius heat is required to produce burns if that 44 degrees Celsius continues to affect the skin for continuous 5 hours. Whereas if we increase the temperature to 60 degrees Celsius, we will see burns in just 3 seconds. So see the difference we are getting by just increasing the temperature to, let's say, 15 degrees. Just by 15, 16 degrees, the time required for producing burns is decreased. So you remember now that burns are dependent on the temperature, time, and the affected body parts. Another concept which I would like to touch is of concept of chronic heat exposure, where a person is exposed to low temperature, but very long duration. Then he develops certain lesion on his bodies. Okay, on his bodies, he develops certain lesions and certain burn characteristics. Now, this is called as erythema ab igne. This can be a very important bouncer question or a very atypical viva question. When the examiner he wants to ask you a question which he sure shot knows that you won't be able to answer. Atypical exam question can be this. It is molted pigmentation and redness of skin, and it is seen in individuals who have a habit of sitting near open fires or heaters for long periods. Who are generally these individuals? These individuals are your society watchmen, your guards who are working in outdoors, winters, okay, laborers, and you generally see it in the anterior aspect of the legs. The pathophysiology of burns is best explained by something called as the Jackson model. Now, what is the Jackson model? What the Jackson model tells you is that whenever there is a burn injury, suppose over here I apply localized heat, let's say I apply a flame over here, where you apply the most amount of local heat in that region, the central main affected region is going to be dead, and it is going to be dead by the means of coagulative necrosis. So this central region is called as zone of coagulation, and around that zone of coagulation is another zone called as the zone of stasis. There is a zone of stasis. What do you mean by stasis in terms of pathophysiology? Stasis means there is less blood flow or less blood circulating around this region. this circle around a central circle of dead tissue. This tissue is dead. Now, this zone of stasis is much more important for surgeon because this is the salvageable tissue. What do we mean by salvageable? Salvageable just means savable. It means that the surgeon, if he does the treatment on time, then this zone can be saved. This circle can be saved. Otherwise, this circle will be lost. Okay. So around this zone of stasis, there is another zone which is called as the zone of hyperemia. What do we mean by hyperemia? Hyperemia is just the opposite of stasis. Stasis is less blood going in and out. Hyperemia is more blood perfusion in that area. Because of there is more blood perfusion in that area, there is redness around that area. So central dead zone, around that dead zone, you see a zone of stasis. Around that zone of stasis, you see a zone of hyperemia. Now, how do we explain it? I meant, how do we remember it? See, if you are Indian, and most of us who are watching this video, obviously we are Indian, so I'll explain it to you by an accident analogy. If you have ever traveled by a big highway, let's imagine this is a big highway. Traffic moves very fast over here, very big national highway, lot of people coming and going in this highway. In the center of the highway, there is a bike accident, and the bike rider died at the moment on spot. So this is a dead body, and a pool of blood, head injury, and this person is now dead. If you have seen Indian accidents, you must have seen on road. If you have seen an accident, you see that there is a dead body or an injured person. Around that injured person, there are many spectators who are just taking their phone out, making reels, just recording or just chit chatting, just wasting time over here. They are not concerned about asking if the person is, or checking if the person is alive or dead, whether he needs some help, moving the dead body to the side, showing some respect. No, they just want entertainment. They just want to spectacle. So these people are not moving. They are just standing over here and not helping also. So, and there will be another group of people who are traveling in high speeds. They don't care about the accident also. And they are just want to go from wherever they get the way, from wherever they can go. So, this analogy, now you can apply this analogy to your burns. In the center, we have a dead tissue. Okay, dead tissue, and we call that zone of coagulation because there is necrosis, and the necrosis is coagulative necrosis. Okay, dead. Around that, there is a savable tissue. These people who are just spectators, this is called as zone of stasis, spectator stasis. And in the periphery, you see this high speed moving traffic. This is the extra blood flow going and coming from the tissue, inflammatory. This is zone of hyperemia. Okay. So this is how you can never forget the Jackson's model. Okay. Just every time, whenever on the road you see some accident, now next time you are going to remember this Jackson's model. And by the way, if you really see an accident, you should go try to do your best and be a good citizen. Don't just remember Jackson's model. Now, every time there is burn and you see this zone of hyperemia, because there is more blood flow going to this zone, this zone is especially red, more red as compared to the surrounding burned region. Now, I'll show it to you in a photo. See this region. This is the zone of hyperemia, zone of inflammation. There is inflammatory border over here. Okay. So this is the burnt tissue. And around this redness which you are seeing, this is the zone of hyperemia. What else can we see in this picture? What we can see is there is a burst blister. The blister has formed and the blister has broken. You can see the edges of that blister. And how's the base of the broken blister? The base is red. That indicates that These burns were antemortem burns because inflammation was set in. These are not postmortem burns. This is the interpretation we can get by seeing this picture. Now, when it comes to burns, there is something called as burn depth. Burn depth, which means how deep is the burn? Is it skin deep? Is it subcutaneous deep? Or is it muscle deep? Is it bone deep? How deep it is? That's called burn depth. There is something called as total burn surface. Okay, there is something called as burn surface, which means how wide is the burn, or what we call more officially total burn surface area, TBSA. How much of the body portion is burned? Hands are burned, hands and feet both are burned, hands and entire lower limb are burned, the head is burned, torso is burned. How much of the body is actually burned over here? Now, the question arises, what kills more? Does burn depth kill more or burn surface kill more? The short answer is TBSA is more important than burn depth. Okay, so coming to the slide, large superficial burns may be more dangerous, not maybe, are generally more dangerous than deep local burns. Okay, so there is a person who has got deep burns in his hand or feet. Nowhere else he has got burns. There is another person who has burned his entire body. Burns are mostly superficial, but some places they are superficial to moderate depth. The person who has burned his whole body, the chances of him dying, the prognosis is going to be much worse with the more body surface area involved. So the question comes, how do you calculate what is the total burn body surface area? How do we estimate TBSA? This estimating TBSA is taught in forensic, it's taught in community medicine, it's taught even in surgery. So mostly it should be taught in surgery, I feel, and forensic. So we apply something called as Wallace rules of 9, okay, which we call as rule of 9. What do we do? This chart, almost every medical student is familiar with this chart. We give 9 for every body part. For the head and neck, we give 9. For each arm, we give 9. Each upper limb 9. Each lower limb 9. Okay, this 9, this 9, or else this whole thing, some say 18. And the perineum is 1%. So this is this every medical student, almost every medical student knows this. There is something which inquires the minds of medical students. They say like, sir, the burns are not like the entire this thing is burned. The burns are not uniform. There are some scattered burns. यहाँ थोड़ा जला है, यहाँ थोड़ा जला है. Okay, small patches of burns are there. Then how do we calculate the body surface area? Now, for that, there is something called as the Palmar method. So the patient's palm, not your palm, the patient's palm. You may be a 6'6" surgeon with very big palms, or you may be very small person with small palms. We take the patient's palm along with the fingers and we consider that 1%. Now, if we calculate it by putting the patient's palm or just the average or just the estimate also. So see the patient's palm and compare it, how much of the skin is burned, and then you calculate the TBSA. So one palm is equal to 1%. So how many palms you are getting? You are getting 3 palms, 4 palms. Based on that, you can calculate small or scattered burns. Sunburns are not included in this category of TBSA. Remember that. And last thing comes is of children. Children have different body proportions. So for children, we use something called as Lund and Broder. There's a different chart and it is taught very well in your pediatrics. So, but always remember, for children, use this Lund and Broder chart. Why? Generally because children have a bigger head and different body proportions. So more body surface area is burned, more is the fluid loss, more is the risk of infection, more is the electrolyte imbalance, and more is the chance of shock. Now we'll go to the classification of burn depth. Now, different authors, based on the type and based on the method and based on the textbook, some authors they have given a 3 degree classification, some have given a 4 degree classification, some have even given a 6 degree classification. Which one to remember? I like to remember the most simplest one, which is called as the modern classification, which is a 3 degree classification. I'll share that with you in a minute. But let's first discuss what are the layers of the body when it comes to burn depth. When heat is applied to the body, let's say that there is a flame applied in this particular region, the burn injury will start burning the epidermis. It will start burning the epidermis. It will go down. It will go deeper. It will involve the dermis. Then it will go further deeper, involve the subcutaneous tissue. Then finally comes the muscles and the bones. So the bones and muscles are the last layer to get affected, whereas the dermoepidermal region is the first layer. With that in mind, now we'll go to the 3 degree classification. Okay. So first degree, out of the 3 degree classification, first degree, we say that burns are first degree burns when the epidermis is involved. Okay, whenever the epidermis is involved, we say it is a first degree burn. We say a burn is second degree. We say that a burn is second degree when the dermis gets involved. And we say a burn is third degree whenever there is involvement of subcutaneous fat. Sir, if there is involvement of subcutaneous fat, but not involvement of bone, not involvement of muscle, then what it is? Basically, the practical funda is that once the subcutaneous fat is involved, bone and muscle are bound to get involved. 99% they are bound to get involved. Why? The reason is that whenever burns extend till the subcutaneous tissue, the fat in the subcutaneous tissue act as a combustible material and it becomes basically a more of a grease, more of a ghee for फर्दर एक्सटेंडिंग द बर्न ठीक है तो आग में दी घी डालने का काम होता है जब सबक्यूटेनियस फैट इन्वॉल्व हो जाता है तो सो वंस स्किन provides some resistance against burn but when it reaches the fat and the fat starts boiling it starts burning it provides as a ghee or a oil and the burn extends drastically and it definitely involves the muscle and bone underneath there once the fat is involved definitely leads to involvement and more destructive burns now what are the effects of burn on the muscle for those who have done cooking on a griller they will know what are the effects of heat on the muscle. First thing what happens is that the muscle gets dehydrated. Second thing, the proteins in the muscle get denatured. Then what's going to happen is it's going to become shortened and contracted. You see those people who have cooked chicken. So if this is a chicken piece, this is a chicken piece and you put it on the griller or on the cooker and you cook it. The size of the chicken piece after cooking is going to get smaller. Why? Because of dehydration, because of contraction of the muscle fibers. Okay. So same thing which happens with the chicken that we cook in the kitchen, same things happens to us when we get burned. Okay. Now, what are the autopsy appearances of a body of burns? See, the body of burns, the autopsy appearance of body of burns depends on how much is the uh, impact of burn injury. In the mild cases, there can be only reddening. Okay. If the burn injury is less, there will only be reddening. What you are seeing over here. Okay. This is the reddening which you are seeing over here. If the damage is more, there is blister formation. See, these are the bursted blisters, blisters which have burst, okay, blistering. So then we'll progress. This is the mildest version is reddening. Go more severe is blistering. More severe than reddening is blistering. Then comes If you go more severe, then comes desquamation, okay? Removal of the epidermis from the dermis. If you go more severe, more heat is applied. In some cases, there may be complete charring of the dead body. Okay, complete charring and complete carbonization. Complete carbonization of the dead body will be there in the most severe cases. Then what happens? And there can be parchment-like appearance on the surface. What exactly is parchment? If you are from India and I am from India, most of Indians, English is not the primary language. So parchment is nothing but a material which is made of skin of the animals and was used in the past for writing. In the past, there was no paper. So people used to make this kind of a parchment from the skin of animals and they used to write on it. And it used to look like this. Okay, so this is what a parchment, this is exactly what a parchment looks like. It has a very dry texture. So there is parchment-like appearance in the burn bodies. Why there is parchment-like appearance? Because what happens is that all of these blisters, they burst. And whenever these blisters burst, they release the serum, okay? They release the serum and this serum dries. So this dry serum gives a parchment texture to the body. Okay. And many other times, what can happen is that there can be soot deposition, which blackens the body. So that further complicates. Finally, what is the pugilistic attitude or a boxer's attitude? See, this is called as a pugilistic attitude or boxer's attitude. I told you 2 slides back that when the effects of burn on the muscle. I told you that what happens is the muscle dehydrates and the muscle contracts. So, same thing when the burns involve the muscle, what happens is that the muscles contract, and generally by default in 90% of the population, flexor muscle are stronger than the extensor. So suppose there is a burn injury over here on the hand, what's going to happen is that this is going to contract. Even though this contracts, even though the extensor should also contract, but flexors are stronger. So the attitude is that of a flexion. And because of that flexion attitude, there is flexed elbows, flexed knees, clenched fist. All of this give a boxer's attitude. And remember, this does not prove, this is very, very important. This does not prove that the person was alive during the fire. Always remember this, that this pugilistic attitude is just heat-induced muscle contraction. It does not prove anything. It does not even prove antemortem burns. It just proves that there is heat muscle involvement of the burns. The muscle depth is so much that muscles have got burned. This only proves the burn depth. It does not prove anything. Now, this is a proper detailed slide showing the boxer's attitude. You can see the exact pictures, how the body is. It's a peculiar stance. There is a generalized flexion even of the trunk, upper extremities, lower extremities, and this is the classic boxer's pose. What is the pathophysiology? The pathophysiology is there is coagulation and denaturation of the muscle proteins. Now, because the flexions are bulkier, this I have already told. Since the flexors are in general stronger than the extensors, the flexors contract more, and that causes this peculiar attitude. This also I have already told this point, that this is a reaction to extreme heat and this can occur even post-mortem. This does not indicate that the victim was alive or he was attempting to defend themselves. This is an important thing. Many times the police, they see this kind of bodies and they think that the victim was trying to defend himself when he was burned alive, or no, it is not a defense injury. Okay, the victim was not trying to defend himself when this injury happened. Now we'll come to the internal findings during autopsy. What are the internal findings that we see in cases of burns? First of all, carbon monoxide poisoning is a feature of burns and we will deal it separately at the end. But right now, let me tell you that carbon monoxide carboxyhemoglobin causes cherry red color of the blood tissues, and it causes the very famous cherry red color lividity. This is has been asked, I think, minimum 5 to 10 times in NEET-PG. But before we discuss all of the carbon monoxide poisoning, you'll ask, sir, how does a person inhale carbon monoxide in cases of burns? So let me explain it to you with an example. Suppose this is your friend's room. This is your friend's room, and this is your friend. A very innocent, happy fellow, your friend, and there is a fire in your friend's kitchen. This is a fire. Okay, this I am drawing in the red is a fire in your friend's kitchen. Now, why does not your friend notice the fire? Because maybe your friend is busy chatting with his girlfriend, or he is busy scrolling Instagram reels, so he does not notice the fire. What happens first? The fumes from the fire the fumes from the fire, they come, the smoke from the fire, they come, and he inhales those smoke of the fire. Before he burns, he inhales the smoke of the fire. And what is in the smoke? It is carbon monoxide. So carbon monoxide poisoning almost always occurs in cases of house fires. Now coming to some more autopsy findings, look at this image. What you see over here, these are pus pockets. So the presence of pus pockets indicates that this is not a case of immediate deaths. Maybe the person was hospitalized for a few days and then he has died in the hospital. Now look at the second image. In the second image, what you see are visceral organs, the intestine and stomach and the visceral organs. What is the appearance of these visceral organs? The visceral organs are partly cooked. Okay, partly cooked appearance of the visceral organs. And another last thing is Curling's ulcer. Curling's ulcer is an important 2-mark question coming even in surgery. These are basically stress ulcers noted in the stomach and duodenum of burns patients. Remember, not immediate burn victim, but burn patient who are admitted in the burn ward, who survive the initial trauma. You see these kind of acute stress ulceration. These are called as curling ulcer. This is a very important 2-mark question for your surgery exams. The critical marker of burn, especially antemortem burn, is smoke and soot inhalation, and this is also a silent killer because in majority of the fire fatalities the death is due to smoke inhalation rather than direct thermal injury. Before the fire flames catches him, he is already unconscious and already drowsy by the carbon monoxide poisoning. Remember this. That is, by the way, one of the few reasons why people do not escape house fires. Because what happens is, house fire starts in, let's say, the kitchen. By the time the fire fumes come to the room in which the other person is sleeping or maybe busy scrolling reels, he has already inhaled the enough amount of carbon monoxide that he is mentally confused, and in that mental confusion he cannot run away. That is why one of the few reasons is that most of these burn victims are found immediately, just immediately 3 feet from the door of the house, because they generally collapse in a state of confusion. They cannot, they try going towards the door of the house, but they are in a state of confusion. They cannot figure out, they do not have the clarity. That's why most of them they collapse right over there. Now, in the respiratory system, when these soot particles go, the soot particles themselves are not that toxic. But what happens is that the modern household items, and in general, all the modern items are made of plastic. They are made of chemicals which are highly toxic. dangerous, highly toxic material when it is converted to fumes. So what happens is that along with the smoke, the person also inhales all these toxic gases, and these toxic gases are what causes death. Now, the absolute proof of the person being alive when there was fire becomes the inhalation of soot. Look at this image. These are soot particles. If the soot particle are present below the level of vocal cord, this is an absolute proof that there was active respiratory effort during fire. Okay, during fire. Over here also you can see the soot particle. This is the soot particles. One thing which even I see experts also confuse, and it is even written in some textbooks, is that the soot particles are a confirmatory sign of antemortem nature of burns. No, in forensic medicine, even a word makes a huge difference. Soot particles are not a sign of antemortem nature of burns. They are only a sign that the person was alive. The person was alive when fire took place. So that means the same thing. Why you are just using fancy words? It is because it when you say that the person died from burns, it means that the person died from flames. But what can happen is that when you see soot particles in the lungs, the person might have already died of carbon monoxide poisoning even before the flames touched him. And what you are seeing, the charring, pugilistic attitude, all of that may actually be postmortem. So, the presence of soot particles in the lungs or in the respiratory passage only indicate that the person was alive during the fire, during the fire incident. That's all. You should not use the word antemortem burns. If soot particles are present in the trachea and respiratory passages, it means that the burns are antemortem. No, even I have done that mistake in the past. Bernard Knight clearly tells that using such terms is not good for forensic experts. If you see soot particles, it only your opinion should be that the person was alive during the fire and he was respiring during the fire. That could not be due to burns, that could be due to inhalation of toxic gases also. So always remember this. If there is soot particle in the tongues, in the nares, in the oropharynx, this does not mean that the person was respiring, he was alive during fire. It could be that the person was already dead and the mouth was open. So because the mouth of the dead body was open, the soot particles can accumulate on the nares, on the tongue, on the oropharynx. So the don't put too much emphasis on soot particles above the level of vocal cord. If the soot particles are present below the level of vocal cord, only then there is active and definitive proof of active breathing. Gastric evidence is also there. If soot particle is found in the esophagus and the stomach, it means that there was active swallowing during fire. Lastly, there is one forensic autopsy finding which is called as singeing of hairs. So what is singeing of hairs? Singeing of hairs is basically, if this is how your normal hair is, this is the root of the hair, this is the level of skin. What happens by burns or by flames is that the protein, basically the keratin in the hair, it gets denatured and you get what you call this kind of a clubbing at the end. So that is called as singeing of hairs. This is another finding you see in cases of burns. Some images I have blurred wantedly because I cannot put those images on YouTube. So over here, one background image I have blurred. But let's focus on one artifact which is seen in burns, is that there are something called as heat ruptures. These are splits in the skin due to contraction. They are important because they can mimic incisions or lacerations, and the police or the lay people, they might think that somebody has cut the dead body, or there is an episode of assault and then they have burned the dead body. So always remember that these heat ruptures are artifacts. These are not real evidence of injury. There is a myth of spontaneous combustion. This myth is not that common in India, but it is common in Western countries like America. The myth is that a person, for example, I'll take give you the example of a person walking on the street. This is a person who is walking on the street, and just randomly while walking on the street, he spontaneously combusts. That is, he spontaneously catches fire. So there is nothing like spontaneous combustion. Always, every time, whenever there were rumors, in especially in USA, there were some deaths where there was rumor that this person spontaneously combusted. If every time we have found some source of ignition, and generally these were people who had consumed alcohol. Because of the intoxication of alcohol, they accidentally caught fire. Another artifact, and this is very important, is the heat hematoma. What is heat hematoma? It is a false hemorrhage, and it is caused by prolonged intense heat to the head, which causes boiling in the blood. In where does the blood boil? In the diploic spaces. Where are the diploic spaces? I'll explain in a minute, don't worry. But they mimic traumatic extradural hematoma, and that is why it is very important that many times in these burn bodies, if it is done by inexperienced people, people with half knowledge, they interpret that there is EDH in the skull, but it is not EDH. Okay, it is the heat hematoma. This is an artifact. Now, what is the diagnostic key? How do you differentiate between EDH and heat hematoma? The diagnostic key is always the honeycomb appearance. The honeycomb appearance of heat hematoma. That honeycomb appearance happens because of the trapped air bubbles inside the hemorrhage, and the color is also not exactly the blood color. It's a somewhat chocolate brown color. This is a very good comparison image between heat hematoma and extradural hemorrhage. You can take a screenshot of it and read it. One thing that I told you that I will explain is the nature of diploic vein. See, if this is the skull bone, there are veins which are running across the skull bone. These bones are called as diploic veins. Okay, so even though there is heat, flames are outside, not yet penetrated the skull, there could be boiling of blood over here, and that boiled blood goes down from the skull bone into the extradural space, and over here you see the formation of heat hematoma. Now we'll come to the topic of scalds. When do we say a burn? When do we say scalds? We say scalds whenever there is thermal injury due to moist thermal damage. What can be moist thermal damage? The moist thermal damage can be hot water, oils, hot oils, molten rubber, some chemicals, steam. Remember, dry heat causes burns, wet heat causes scalds. Generally, these are seen in household accidents, and pediatric population is more involved. And always look at the pattern of scalds. Over here, you can see that there is scald injury at one particular level. Now, that indicates that the baby was submerged in the water till this level. One part of accidental scalds or even other types of scalds is that there are trickle marks. What are trickle marks? These are flow pattern that follow gravity, and they help indicate the position of the victim. Remember, see, these are trickle marks. This mark. This is how the hot water flows, the flow pattern. And this always follows the gravity, it always runs down. Okay, there are no trickle marks like this upward going. Now, what are some hallmarks of scalds? Scalds represents first degree dry burns and they are accompanied with reddening, desquamation, blistering, and they lack the destructive carbonization which we see in open flames. There is a lack of charring. Remember, in scalds there is no charring. Even in dry burns, charring takes place only when high heat is there. There is going to be blistering and desquamation. Over here you can see blistering and desquamation. There is always a demarcation line, and that demarcation line follows the fluid contact movement. It means that the fluid came till here and then the fluid did not move further. Again, here you can see the trickle pattern that you can see with the effect of gravity, the hot fluid is traveling downwards. This will give you a idea of the relative position of the victim. Again, roasting, charring, singeing of hair, all of these you see in dry heat burns, whereas in scalds you do not see all of these. What you see instead is blistering, trickle patterns, etc. Now look at this slide. Again, it is repeating what I've already told. Dry heat, there is charring. Moist heat, no charring, no carbonization, no singeing of hairs, and there is a characteristic sharp demarcated edge when it comes to scalds. You can take a screenshot of this table if you want to. Now we'll come to the core question. How to determine if a burn is antemortem or if that burn is postmortem. The most important thing is that antemortem burns, there is something called as the line of redness. The line of redness, this is most characteristic of antemortem burns. I have shown you images where I have shown you the line of redness also, and the line of redness shows that there is an active inflammatory response, and if there was active inflammatory response, it means that the person was alive, the active circulation was there. See, this is the histological section of how a blister looks. This is a blister, but note something below the blister on a histopathological site. Over here, you see a lot of inflammatory cells. Okay. So these inflammatory reaction you see only in cases of antemortem burns. Now we'll come to a very important biochemistry evidence. Carboxyhemoglobin percentage. If the carboxyhemoglobin percentage is more than 10%, it means that the person was definitely alive during and the person has done some smoke inhalation. When the fire was taking place, this person was alive and he has inhaled the fumes of the fire. Carboxyhemoglobin up to 5% can be present in normal individuals. Up to 5% of carboxyhemoglobins can be present in normal individuals. Generally, these are individuals who smoke. Okay. But if it is above 5% and if suppose you get levels like 10%, then you can definitely say that breathing occurred during the fire. That means that the person was killed and then fire ignited. That's not the scenario. So this is the role of carbon monoxide. There should always be some caution with cyanide analysis because cyanide may be detected in fire victims, but cyanide is also a sign of normal postmortem decomposition. Therefore, cyanide analysis is not a reliable marker. Okay, it is not a reliable marker. What are the gold standards? The gold standards of diagnosis are always elevated carboxyhemoglobin and always soot deposition in the airways below the level of vocal cords. Now let's look at the manner of death. Accidental burns are especially scalds are seen in children, epileptics, elderlies, and they occur in domestic settings like kitchen, bathroom, etc. If there are suicidal burns, the people generally use some accelerants like kerosene or petrol. So the kerosene or petrol is positive and there is distinctive odor of these materials. Homicidal burns like dowry deaths, etc. And you should always look for some defense wounds. You should always look for some signs of struggle, etc. when it comes to dealing with homicidal burns. What is the thermal injury checklist? There is a systematic approach of how you approach the burn. First, you assess the depth. Okay, you see whether these are superficial or full thickness, if they are involving the muscle or not. First, once you have assessed the depth, then you go for assessing the extent. Apply the rule of 9 and calculate the TBSA. Once you have calculated the TBSA, then you look for other things like is there any charring, is there any singeing of hair, or there is any blistering. Then you try to identify the source of burn, whether it is dry burn, whether it is a moist burns or scald. Then you go for all of that. So for example, chart body, तो chart body में ये सब का सवाल ही नहीं उठता. Finally, you map all the patterns. You reconstruct everything and you try to give your best reconstruction to the authorities. Now, what does the medico-legal officer do in burn cases? Many times you identify the diseased, many times the identity of the disease also is lost. So you can do you can do DNA analysis and help in the identification of the diseased. You need to obviously give the cause of death, you need to give the time since injury, and lastly you need to find out whether these are antemortem burns or postmortem burns. Now, there will be cases where it is doubtful to say whether the burn is antemortem or whether the burn is postmortem, because up to 1 hour after death, most of the antemortem findings are seen. So, in such places where the doctor cannot confidently say, he should always use the term perimortem. Okay, do not confidently give antemortem, do not confidently give postmortem. If you are not genuinely confident, always use the term perimortem. So that was our lecture on burns. It turned out to be a very lengthy lecture. It took me 2 days to record. So hope you liked it. I have done my maximum to cover all the points. Still, I think I have not done justice with this topic, and still there might be one or things which I am missing. If you have come till this part of the lecture, I'm really thankful of you. Hats off to your dedication. Thank you. Keep supporting me. Keep watching my videos. I'm only doing this for you. Thank you.